Welcome to Medical Specialists Associates educational series on topics in critical care medicine. I'm Christopher Voss, MD, MS, a Harvard and Stanford University trained physician board certified in anesthesiology, critical care medicine, and neurocritical care medicine. This educational video is on how and when to use the ARDS protocol in patients with respiratory failure. Acute Respiratory Distress Syndrome, ARDS, is a life-threatening condition that requires careful, evidence-based management. Today, we'll explore the ARDS protocol, its application based on severity, and the critical factors to consider during treatment. What is ARDS? ARDS is a severe lung injury caused by conditions like sepsis, pneumonia, or trauma, leading to inflammation, impaired gas exchange, and hypoxemia. Diagnosis involves rapid onset of respiratory failure within a week of a known clinical insult. Bilateral opacities on chest imaging not explained by other causes. PaO2 to FiO2 ratio of less than or equal to 300 millimeters per mercury, classifying the severity of ARDS. Exclusion of cardiac-related pulmonary edema. Breaking ARDS down by severity. ARDS severity is categorized by the PaO2 to FiO2 ratio, which helps guide intervention. Mild ARDS, PaO2 to FiO2 ratio between 200 to 300 millimeters per mercury. Moderate ARDS, PaO2 to FiO2 ratio between 100 to 200 millimeters per mercury. Severe ARDS, PaO2 to FiO2 ratio less than 100 millimeters per mercury. For moderate to severe ARDS, the ARDS protocol is critical, particularly in managing lung protective strategies and considering early ECMO referral for patients with severe ARDS. When to use the ARDS protocol? The ARDS protocol should be initiated for patients meeting the ARDS criteria, especially those with moderate to severe ARDS. PaO2 to FiO2 ratio is less than 200 millimeters per mercury, who require mechanical ventilation. Key components of the ARDS protocol. 1. Lung protective ventilation. Using low tidal volumes, 4 to 8 milliliters per kilogram of ideal body weight, is essential for preventing ventilator-induced lung injury. Plateau pressures should be kept less than 30 centimeters of water to reduce the risk of barotrauma. 2. PEEP and FiO2 management. The ARDS protocol provides a graph to titrate PEEP and FiO2 based on the patient's oxygenation status. In moderate to severe ARDS, higher PEEP settings are often necessary for optimal oxygenation and lung recruitment. 3. Permissive hypercapnia. Permissive hypercapnia, allowing slightly elevated CO2 levels, is a common strategy to avoid high ventilatory pressures and subsequent lung injury. As long as pH remains above 7.25, this strategy can be safely employed. 4. Prone positioning. Prone positioning is recommended for patients with severe ARDS, PaO2 to FiO2 ratio less than 150 millimeters per mercury. This improves lung recruitment and oxygenation, with sessions lasting at least 12 to 16 hours per day for maximum benefit. 5. Neuromuscular blockade. In patients with severe ARDS, early neuromuscular blockade for up to 48 hours can improve patient ventilator synchrony and oxygenation, particularly when prone positioning is being used. ECMO. Consider early use. Extracorporeal membrane oxygenation should be considered early for patients with severe ARDS who fail to improve on conventional therapies. By moving to ECMO sooner, the goal is to minimize ventilator-induced lung injury, providing a protective option for patients with refractory hypoxemia. Adjunctive therapies in ARDS. 1. Fluid management. Conservative fluid management is essential in ARDS to reduce pulmonary edema and improve lung compliance. Diuretics may be employed to achieve a negative fluid balance without compromising perfusion. 2. Driving pressures. Although driving pressures, P-plat minus PEEP, are not formally part of the ARDS protocol, they are an excellent complementary metric. Lower driving pressures, ideally under 15 centimeters of water, are associated with better outcomes by reducing lung overdistension. Physicians may choose to monitor driving pressures independently, especially in cases where adherence to the full ARDS protocol is challenging or not feasible. When to transition off the ARDS protocol? As lung function improves, patients can be weaned off the ARDS protocol. This involves gradually reducing PEEP and FiO2 while maintaining adequate oxygenation, initiating spontaneous breathing trials when the patient is more stable and able to tolerate reduced sedation. Special considerations. 1. ARDS in COVID-19. In COVID-19-related ARDS, management follows similar protocols, but patients may require prolonged periods of mechanical ventilation and specific immunosuppressive therapies. 2. Driving pressures and outcomes. Research shows that maintaining low driving pressures is independently linked to improved outcomes, even outside the ARDS protocol. Keeping driving pressures low can be crucial in reducing ventilator-induced lung damage. Conclusion. Understanding the ARDS protocol is critical for managing patients with respiratory failure. The protocol provides structured, evidence-based guidelines that help reduce lung injury, improve oxygenation, and enhance recovery. Additionally, monitoring driving pressures and considering early ECMO are valuable strategies to improve outcomes. To learn more about critical care medicine, please visit us on our website at medspecialists.net and subscribe to our YouTube channel.